Hello everyone, today we'll discuss another multiple choice question and this is USMLE based MCQ. The question is a 56 years old man comes to the hospital due to progressive fatigue and weakness. Okay, and the medical history also includes type 2 diabetes mellitus and obesity. Laboratory results as follows, that is serum chemistry shows sodium is about 138 milliequivalents per liter, chloride 110 milliequivalents per liter, and bicarbonate is about 18 milliequivalents per liter. Okay, then which of the following is the likely diagnosis in this case? Option number 1, diabetic ketoacidosis, 2, lactic acidosis, and option number 3, obesity hypoventilation. Option number 4, primary hyperaldosteronism, and option number 5, that is renal tubular acidosis. Okay, so among these 5 options we have to find out the probable cause for this case. Okay, so now they have given the values like sodium, chloride and bicarbonate. Bicarbonate is about 18 milliequivalents per liter. So normal it is about 24 to 28 milliequivalents per liter. Here bicarbonate levels is decreased. So loss of bicarbonate ions in the serum, it denotes metabolic acidosis. Okay, now we have to find out the anion gap. Here metabolic acidosis with normal anion gap and metabolic acidosis with elevated anion gap. Okay, how to calculate here anion gap? So it measures the differences between positively charged ions and the negatively charged ions. Here positively charged sodium 138 minus negatively charged like chloride 110 plus 18 128. So 10 milliequivalents per liter, that is 138 minus 128, 10 milliequivalents per liter, that is the anion gap in this case, and normal anion gap is about between 4 to 12 milliequivalents per liter. So here anion gap is normal. So metabolic acidosis with normal anion gap. What is the mechanism? The main mechanism for this is loss of bicarbonate ions from the serum. Okay, what are the causes? First one is severe diarrhea, loss of bicarbonate ions in the gastrointestinal tract, renal tubular acidosis, that is loss of bicarbonate ions in the kidneys, and excessive saline infusion. These are the causes for metabolic acidosis with normal anion gap. Next is metabolic acidosis with elevated anion gap. Okay, here mechanism is accumulation of unmeasured acidic compounds in the serum. Okay, and it causes elevated anion gap, that is more than 12 milliequivalents per liter. What are the causes? One is diabetic ketoacidosis, 2 lactic acidosis, 3 ethylene, methanol and ethylene toxicity, salicylate toxicity, renal failure due to uremia. These are the causes for elevated anion gap with metabolic acidosis. Okay, now by this we come to know this is a case of normal anion gap with metabolic acidosis. This is also known as NAGMA, that is non-anion gap metabolic acidosis. For this, the most common cause for non-anion gap metabolic acidosis, one is severe diarrhea and second one is renal tubular acidosis. So here among these 5 options, renal tubular acidosis will be there. So that is the probable answer for this question. And coming to the diabetic ketoacidosis and lactic acidosis, option number 1 and 2, okay, it occurs due to the accumulation of unmeasured acidic compounds which denotes H plus hydrogen ions, and this will bind up the serum bicarbonate and reducing the buffering capacity of the blood and resulting in metabolic acidosis. Okay, This is metabolic acidosis. And remaining anion component resulting in elevated anion gap in these cases, diabetic ketoacidosis and lactic acidosis. And in case of lactic acidosis, due to the accumulation of lactic acid, okay, and unmeasured acidic compounds, they will denote H plus ions, hydrogen ions, they will bind up and reduces the buffering capacity. Okay, so these two are causes for elevated anion gap. Obesity, hypoventilation. Because of obesity, there is a hypoventilation, leads to retention of carbon dioxide. So respiratory acidosis will be there. And a compensatory metabolic alkalosis occurs in obesity with hypoventilation, with increase in the bicarbonate levels. That is expected in obesity hypoventilation. Because of carbon dioxide retention, respiratory acidosis, a compensatory metabolic alkalosis with increase in the bicarbonate levels is expected in obesity hypoventilation. Coming to the fourth one, primary hyperaldosteronism. It was discussed in the last video. It is also known as Cone syndrome. Due to the excessive loss of hydrogen ions in the renal tubular collecting duct, resulting in metabolic alkalosis with increase in the bicarbonate level. So here also HCO3 minus levels are elevated, okay, due to loss of hydrogen ions, H plus ions in the renal tubular collecting duct. Okay, so finally the option number fifth one, renal tubular acidosis. Okay, that is the important common cause for non-anion gap metabolic acidosis. So answer is option number 5. Okay, and this is also known as hyperchloremic acidosis. Okay, because of loss of bicarbonate ions in the gastrointestinal tract or kidney, results in relative increase in the H plus ions, and along with that increased chloride levels, because normal chloride levels is about 96 to 106, here 110. Okay, so relative increase in the chloride ions in the serum, okay, to maintain the electronegative balance. That's why it is called hyperchloremic acidosis. So non-anion gap metabolic acidosis is also referred as hyperchloremic acidosis. So here answer is fifth one, that is called renal tubular acidosis. Okay, thank you all.